please.
Thank you so much, Dr. Pawan. जो सर की हॉस्पिटल जाने से लास्ट कॉल थी उससे पहले वो ये थी कि निधि ये मीटिंग स्टॉप नहीं होनी चाहिए, ये क्लासेस स्टॉप नहीं होनी चाहिए. और just to honor that last wish, much as we are all saddened by whatever has happened in this week, और हमारे सब में जैसे डॉक्टर पवन ने बोला कि अभी वो that safety of having him behind us or having his hand over our head, we miss him so much, but we have to make this forum so strong that he is proud of us and he feels vindicated that his effort has not gone waste. And it is only because of those वो words अभी भी मेरे कानों में गूंज रहे हैं, मेरे दिमाग में गूंज रहे हैं, that निधि ये क्लासेस बंद नहीं होनी चाहिए. So we've decided that the hot topic for now, right now, is mucormycosis. I will do a very, very short presentation just for the sake of continuity. And after that, we will leave the house open for your messages. I would request all of you to mute your mics so that we can finish this class as quickly as possible and devote more time to honoring Dr. KK with your messages. So, आजकल we are hearing a lot in newspapers, on media, and in the WhatsApp University about black fungus. Black fungus is an opportunistic infection. ये सबको affect नहीं करती है. इसका main problem COVID के साथ, immunocompromise के साथ आ रही है. Is it really that common? So even though the cases are rising now and we expect that over the next 10-15 days the cases will rise further क्योंकि people are recovering और उनका जो immune exhaustion हुआ है वो अभी पूरी तरह recover नहीं किया है. So we are expecting कि cases अभी थोड़े rise करेंगे. And the important thing about black fungus is that because it invades the blood vessels, because it survives in a thrombotic environment, जो कि COVID create करता है, it can be both vision threatening and life threatening. जो COVID में हमारे को immunocompromise और immune dysregulation दिखता है, impaired neutrophil response, lymphopenia, everything is contributing to the black fungus becoming what it has become. It is a rapidly progressive disease. So black fungus दो तरह से देखी गई है. एक जो within 3 to 4 days becomes so fulminant that from the nose to the eye the distance is covered within 2 days. And yet there is another variety, less common, जो 2 से 3 हफ्ते में धीरे धीरे progress करती है. The chronic or 4-week course is slightly better prognosis. There is no preventive treatment for mucor. It can either be just restricted to the nose where it is easier to treat, to the nose and sinuses where it is still treatable with very good outcomes. When it invades the orbit, the outcomes sharply drop. And when it invades the brain, they drop to nearly 70 to 80% mortality. Pulmonary mucor has also got very high mortality. Renal, gastrointestinal, and disseminated mucor have nearly 100% mortality. It is on histology seen to be invading blood vessels. It not only invades the vasculitic vessels which COVID has created, but it creates its own vasculitis, its own thrombosis, downstream infarcts, and hemorrhages. and neutrophilic infiltrates, which further decrease available neutrophils to fight the fungus. In COVID, we have seen increased IL-6 and monoclonal antibodies that have been used in therapeutics have resulted in more susceptibility to it. Lymphopenia and neutropenia both predispose to it. Pre-existing diabetes, which is made worse by some treatment modalities, or the diabetes induced by the virus itself. Both hyperglycemia and acidosis promote the growth of fungus. The respiratory failure also causes acidosis, which again causes protonation of the ECF and causes fungal growth. Iron dump and increased available circulating iron is also a factor that contributes. And I think steroids have been an easy target, but it's more the combination of steroids with broad spectrum antibiotics, which has resulted in the competition being eliminated for the fungus. Classically, the ulcers on the skin, on the gums, on the palate, these ulcers are very classic with a halo and a blackish discoloration. It usually does not start with this black eschar. Usually you will just see anesthesia or paresthesias. People might say that they have a loss or diminished sensation on the cheek, palate, around the nose, below the eyes, tooth pain, gum ulcers. The CNS involvement is shown by two routes, either through the optic nerve where it invades the brain, or through the cavernous sinus. With cavernous sinus involvement, again, the mortality is nearly 100%. Initial stages, it might be restricted just to the nose, and classic black eschar is available to see. Palatal discoloration, purplish hue, and CT MRI findings that suggest the sinuses getting involved. Ethmoid sinuses are the most commonly involved. It is from there that it invades the rest of the sinuses. Sentinel signs. This is what I would like everybody to understand, remember, and refer for early endoscopy. Persistent headache, which is not responding to usual medication, especially if it is only one side of the head, and this patient is not got a history of migraine. Nasal obstruction and discharge. The discharge may not be blood-stained. Pain over one half of the face or swelling over one cheek, loss of sensation over the face, around the ala or in the infraorbital area, discoloration of the face, even purplish discoloration around the nose or the eyes, fresh loosening of teeth, discoloration over the palate or palatal ulcers. These sentinel signs are extremely important to track. We'll skip through this and through this, but I only want to point out that GRP78 seems to be a common factor between mucor, diabetes, and COVID. Platelet activation seems to be a common factor between mucor and COVID. So in early diagnosis, if somebody is really suspecting, it is better to over-investigate rather than to lose the time. Diagnose early and start treatment early. There is no alternative to radical surgical debridement of the fungus that you see, and to start amphotericin B as quickly as possible. We'll skip through this also. The antifungal agents that we are able to use are Ampho B. If you add echinocandin to it, then you are working on both the cell wall and the cell membrane of the fungus. The immune exhaustion that we notice with neutrophils and lymphocytes being exhausted can somewhat be helped with thymosin alpha. Posaconazole is not recommended as a first-line treatment. because it is only a fungostatic, it is not a fungicidal. However, after surgical debridement, if the patient is not able to tolerate ampho-B or needs to be switched, because ampho-B is going to be infusion therapy, or switch to oral therapy, then it might be used as a switch therapy. But this will need to be continued for 3 to 6 months with serial MRIs to follow the progress of the patient. Um, the various types of amphotericin B and echinocandins, we will not go into details here, but methylene blue recently down south has been shown to have some effect, and people are recommending that the humidifier fluid should be laced with methylene blue or with potassium permanganate to kill the fungal spores before they are inhaled. Amphotericin B is a very toxic drug. It has to be administered under very strict medical supervision. Uh, Hydration should be ensured. 200 ml of dextrosaline before, 200 ml of dextrosaline after infusion. Infusion will take about an hour of slow intravenous drip. 50 vials, 6 vials each diluted in 12.5 ml distilled water would give you 300 milligram of amphotericin B in 75 ml solution. This 75 ml solution is further diluted into dextrosaline and infused over the next 60 minutes. The test dose must be given first. The amphotericin B drips may need to be continued for 14 days or till the patient tolerates them. Interestingly, the lipid-based amphotericin B gel is now available, which after surgery we may be able to apply to the local areas and improve outcomes. That brings me to the end of today's class, which I just wanted to honor, sir, which I have done. And I think I will leave the house open to Dr. Preeti and Dr. Pawan for further.